Thank you for a kind introduction, Chairman. It's so honor for me to be here. Today's my topic is endoscopic management for upper GI hemorrhage. I have nothing to disclose. Non-variceal upper GI gastrointestinal bleeding remains a common and potential life-threatening condition. The incidence is approximate up to 80 cases per 100,000 population annually. Despite advances in endoscopic therapy, mortality still range from up to 10%. Therefore, optimal management requires not only hemostasis but also systemic patient care. Post-gastrectomy bleeding is less common with an incidence of up to 4%, but carries significant mortality. We can classify bleeding based on timing and location. Management options include endoscopy, radiologic intervention, and surgery. Among these, endoscopy is increasingly the first-line modality. Because of time limitation, I would like to focus non-variceal ulcer upper GI bleeding. Key concept of endoscopic hemostasis timing is not as soon as possible, but as soon as safety possible. That means immediate endoscopy is not always beneficial and may even be harmful if resuscitation is inadequate. In this study, only high-risk patients showed a favored survival outcome of urgent endoscopy, which means within 13 hours, but low-risk patient did not show survival benefit after urgent endoscopy. In this study, there was no difference in mortality rate between urgent, early, and delayed endoscopy group. The authors suggested that treatment of patients' underlying disease and appropriate resuscitation should be done first. According to ESG and ACG guidelines, early endoscopy within 24 hours is recommended. Urgent endoscopy, which means that within 12 hours, does not improve outcomes. Very early may worsen outcomes. The only exception is a patient with ongoing active bleeding, where earlier intervention may be justified. This is the famous classification, the Forrest classification. Endoscopic hemostasis is indicated in active spurting bleeding and oozing from ulcer base and non-bleeding visible vessel. These corresponded to high-risk Forrest classifications. In ESG 2021 guidelines recommended to consider aggressive endoscopic hemostasis for Forrest B region, as well as high-risk lesions. The reason is a relatively high rebleeding risk of Forrest 2B regions. According to the multi-center study, this study showed a rebleeding rate of Forrest B region group similar to that of high-risk regions. Forrest 1A ulcer on the posterior wall of the duodenal bulb should be one of challenging bleeding, should be regarded as a high-risk region because active spurting and difficult skull position and possible GDA, gastroduodenal artery involvement all reduce the durability of standard endoscopic hemostasis. There are several landmark studies about outcomes of endoscopic bleeding control. In 1988, adrenaline injection showed 100% hemostasis, but 24% rebleeding. In 2002, the study showed to evaluate optimal volume of adrenaline injection, at least 13 milliliter of adrenaline is effective. Combination therapy, typically adrenaline plus thermal or mechanical methods, significantly reduce rebleeding and need for surgery and mortality. This is now considered the standard of care for high-risk regions. Clip device is conventional tool for hemostasis. Especially TTS clip is quick resolution and instinct to use. Result of clip hemostasis is equivalent to thermal modalities and better than injection modality. This procedure has a limitation. The clip always tries to access at 90 degrees perpendicularly. Priority injection could be helpful to get a vision because of excess angle, posterior duodenal bulb, posterior wall of gastric body, and lesser curvature of stomach are difficult location to apply clip. These anatomical and technical limitations are important in selecting alternative strategies. This video is about endoscopic hemostasis using TTS clip. As you can see over here, a spurting bleeding lesion, and try to access perpendicularly. It's important. And fire. Then we can see the successful hemostasis. Here are characteristics of various type of clip. Maximum open width is up to 14 millimeters. Jaw of clip length is 10 millimeter, and clip length is 16 millimeters. Over the scope, clip provides stronger compression and full thickness capture. These devices include large vessel, fibrotic ulcer, failed conventional therapy. Increasingly used as first line in selected high-risk cases, they can apply with conventional endoscopy because the clip device is similar, applied to cap. Here's a video from the commercial, and this video is actually ulcer bleeding patient. We can apply the over OTSC like this over the scope. In actual endoscopy, you can see the ulcer and with the bleeding. If you want to capture the tissue, you can use the anchor like this, or you can just suction to capture the tissue. After firing, we can see the large metal clip like this. This is the follow-up endoscope finding. Recent multicenter RCT showed efficacy of OTSC as primary line endoscopic hemostasis for non-variceal ulcer gastrointestinal bleeding. It showed better successful hemostasis and lower 30-day rebleeding rate. For the Forest 1 duodenal ulcer, I would like to favor TTS clips only when the bleeding point is clearly accessible and the scope is stable. In the posterior bulb lesion, especially with the fibrous or a large caliber vessel, I would escalate early to OTSC rather than persist with the multiple suboptimal TTS clips. Next one is a thermal hemostasis. There are two types of thermal hemostasis, contact and non-contact method. Monopolar and bipolar is a familiar device for a surgeon to use. Argon plasma is not effective method control bursting bleeding, but useful to control diffuse oozing region. I recommend to you to know concept of cooperative coagulation to seal up bleeding arteries. That means press stigma to interrupt blood supply through vessel. Circulating blood could cool down around the stigma, and it could make incomplete hemostasis. So we have to compress and stop the circulation and give some thermal energy. Topical agents such as hemospray and endoclot is inert and non-allergic and inorganic powder. They inserted via catheter downscope, only effective when ongoing bleeding because they interact with the blood and water. They can adhere to bleeding site and make effect of mechanical tamponade. As you can see, the powder loaded behind the catheter and you can shoot with the air, and even you can use the compressed air pump. Here's the videos. Patient who underwent gastrojejunostomy with the diffuse oozing from the multiple site, like this. So we decide to use some topical agent like this. We applied endoclot. The powder interact with the blood and made a thick barrier like clot. And you have to apply enough topical agent to stop bleeding. And final endoscope finding is here. The outcome of endoscopic management is quite good. Almost all cases were successfully controlled. In case of peptic ulcer bleeding, to treat underlying comorbidity was important. Post-endoscopic PPI using is important for successful hemostasis. Standard regimen is 80 milligram IV bolus injection and followed by 8 milligram per hour infusion for 72 hours. This stabilized clot formation and reduced rebleeding risk. Restrictive transfusion strategy is generally recommended. Target hemoglobin around 7 to 8 grams per deciliter in stable patient. Overtransfusion may increase rebleeding risk. All patients should be tested for Helicobacter pylori. If positive, eradication therapy is mandatory. This significantly reduces recurrence of ulcer bleeding. Management requires balancing bleeding versus thrombotic risk. Key principle is restart aspirin early if cardiovascular risk is high. Prepare COX-2 inhibitors plus PPI over NSAIDs. Multidisciplinary decision-making is essential. Routine second endoscopy is no longer recommended. It should be reserved only for clinical evidence of rebleeding. We can predict outcomes several scoring system. Local risk scoring system is one of useful methods for prediction of patient prognosis. This system evaluated patient age, comorbidity, presence of shock, source of bleeding, and stigma of recent bleeding. According to local score system, mortality up to over 50% in over 8 points group. This is the algorithm for the upper GI bleeding patient. The standard approach includes resuscitation and risk assessment and endoscopy within 24 hours and evaluate with the forest classification to decide the modality of hemostasis and combine therapy and PPI infusion. If rebleeding occurs, repeat endoscope and consider transarterial embolization or surgery. This is my last slide. Early risk stratification is essential. Combination therapy is the current standard, and OTSC and topical agent are expanding indications. Predefined strategy for rebleeding is critical. The field is evolving toward precision endoscopic hemostasis. Thank you for your attention.
Good afternoon, everyone. And I would like to thank you, the organizing committee, and also Professor Philip, to moderate this session and for the invitation for me to share my experience today. Topic is how to get ready for doing ESD. I'm Dr. Supakij Khomvilai from Surgical Endoscopy, Chulalongkorn Hospital, Bangkok, Thailand. And I have no disclosure. And this is my hospital in the center of the Bangkok, in the capital of Thailand. And I'm the colorectal surgeon, and this is our team. And in our team, we working as a family, right? And I took care of the, oops, sorry. Okay. I took care of our surgical endoscopy in our hospital, and this is my younger colleague, Dr. Sukit. ESD, the endoscopic submucosal dissection, the concept is to cut into the submucosal layer to remove the lesion en bloc as one piece. And why ESD is it's not moved. Again. Sorry. It's coming. Okay.
Yes,
Yeah. Yes, but it's not.
If it's gone, you have to move it around.
Yes. Okay. Yeah. So why ESD is popular? I asked the AI. That's why the ESD is popular right now. The answer is very interesting. Says the better technology, superior outcome, and then global moving forward to organ sparing the treatment. So exploring each section, organ sparing method is like when you compare the endoscopic treatment to the surgery, especially in the rectal cancer surgery. So you have to remove the part of the rectum, and it's challenging, and then have more morbidity compared to the endoscopic treatment. And sometimes we have to create the ostomy. And colostomy is not just after the operative and then it's finished. It's a long-term complication that you have to face to the prolapse and retraction and everything, and all you know that. And for the outcome, when you're comparing to the piecemeal to the en bloc, and then this is the specimen, and you know that with the en bloc you can get a more accurate pathologic study. And as the same with the TME of the rectal cancer surgery, good TME, lower recurrence, it's the same thing when you compare the piecemeal to the en bloc. And it's confirmed by the Japanese. They're using their ESD for a long time, and they have several studies showing that the en bloc is better than the piecemeal. And so what you have to keep in mind if there's some part of them that is cancer. So en bloc is the answer to do. How about the technologies? Nowadays the endoscopy is go beyond, and now it's very good. And with the image enhanced endoscopy, we get the better detection using the TXI, which now I'm using instead of the white light. And accurate characterization, new generation of the NBI is very sharp, and then you can see it's very clear, the detail of the lesion. And with the IDI, when you face with the complication like the bleeding, so you can stop it easily. And the device, like the traction device, is nowadays I believe that this thing can help you to do the ESC is more easier. And like this, in this lesion, when you have the traction device, so you can get into the submucosal layer is better than before. And so you can complete the resection using the technique like this. And with the training and then the standardization, nowadays make the ESD is more spreading to the world and to the Western country. And that is how ESD is very popular right now. And how could we get started with the ESD? So this is how I teach our fellow to do the ESD. So starting with the knowledge, they have to know that which patient that should get the ESD and which lesion is appropriate to do the ESD. Not every lesion you can do the ESD. And for the equipment and tools, they have to know that what equipment that they need to have in case of the complication happen and in use during doing the ESD. But they have to know that their own equipment, when they're going back to work in their hospital, any equipment that they have to familiar with the equipment that they have, because you cannot get every equipment that you want, and you have to familiar what you have. And for the technique and the skill, starting from the observation. So I let them learn how to do it by observation in the case, and training in the workshop and in the model first. Don't start it in the real patient. It's very harmful. And then and then review the whole case, uncut version, not just look at the good part of the ESD. No, you should study from the uncut version, and then starting practice. You compare to the normal endoscopic resection, and then I recommend to do the pre-cutting EMR first, to familiar with how to control the knife and the scope. And then start your own case. This is how I teach them to do the ESD. And the most important factor for the successful of the ESD, I believe that it should be the patient selection. So first they have to know that which lesion is supposed to do the ESD, not all of the lesion that you can do. ESD you can do in the cancer, of course, in the early cancer, the T1 colorectal cancer is okay. And in DGIST, they have the indication, the benign, the T1 shallow, and then the fibrosis. The accurate endoscopic diagnosis is the key. So we're using the IEE to see that which lesion that we can resect, and then which lesion we can should do the surgery. And with the NBI, using the NICE classification and also the GENET classification. So this is the picture showing that the NICE type 2 and type 3. I usually use this picture to teach them that how to distinguish the cancer from the benign. And then if the lesion is look like the benign on the left, so it should be benign. It should look like the cancer on the right, it should be the cancer. In the middle, maybe it's the early cancer, something like this. And this is the NICE type 2, the tubular adenoma. And another case is the same, is the tubular adenoma with the NBI. And this is the isolated lesion. And how about this one? Putting an NBI on. This is the cancer of sure, but this is the early cancer, the GENET 2B. And when we see the lesion, we use the NBI to characterize, and we decided which procedure we should do. And if you cannot do it, just take the photo. No tattooing or the biopsy. So next is about the equipment that they have to use. Starting with the scope. For me, it's on the right side, colon, using the PCF H290 TIY. Is the scope for the ESD. It's more flexible, smaller scope. And for the rectum, I use the gastroscope to do the ESD. But some of the doctors are using the bigger scope because the picture is more clear, but it's difficult to get into some part like the littofraction, something like that. So from the picture like this, you can understand that the scope that I use most is on the left side. The PCF is the designing for the ESD especially because it's the flexible, small size, so we can get into some position is really easy compared to the bigger size on the right. And the knife, coax gasper, to in case of you faced with the bleeding, the lifting solution, and also the lens cleansing. Solution that I use, we don't have the hyaluronic acid. We use a glycerol in the most case, mixed with the adenine and indicocamine. Smaller syringe to injection. And needle, I use the 4 millimeter needles, a small size, 2060. And the cap, I use the transparent cap, the taper one from the Fuji, because it's easier to get into the flap. But the vision will be limited because it's the taper one. The knife, using the needle type, I use the Noel knife as a main knife, but sometimes using an IT knife and the scissor type knife. And endoscopic clip is the must that you have to familiar with when you have the perforation or the bleeding. This is the equipment that you have to familiar to use. And this is my endoscopy using the ESD under the general anesthesia and have the CO2 and flushing pump and also the electrocautery. And when you're doing the ESD, make yourself comfortable. It's like I'm doing the ESD during the sitting because I have a problem with the backs, and then don't have to rush. And then when you start rushing, hurrying, everybody will running around the room, and then it's not good for the procedure. For the technique that we doing the ESD, I show you my case is one case. The LST non-granular pseudo-depressed type, not so big size on the transverse colon. I do ESD in this case, lifting with the glycerol, and start doing the cutting into the submucosal layer, using the cap to controlling, and as you can see that sometimes the bleeding is occur, but with the power of the electrocautery, you can stop the bleeding. It's very easy. And then keep cutting into the submucosal layer like this. And using the taper type, you can get into the submucosal layer as a traction, and then the opening the flap and get into the submucosal layer and keep cutting into the brownish layer. So it's like this, and you can see here is like using the cap to opening and then keep cutting into the submucosal layer. And when you sometimes, because of the knife have the jet function, so sometimes if the lifting is gone, you can additional injection without removing the knife and using the needle. So the equipment now is very good. You see here, injection and then keep cutting. So with the new equipment is helping us like this to complete the procedure is very fast and then easier than before. And this is the final cut. This is after the dissection. And usually I close it in every case if I possible because to prevent the bleeding. And this is the finish. Dissection time is not so long, 26 minutes, and then a pathologic is in high-grade dysplasia. So the principle is create the tension in the submucosal layer and cutting in the perpendicular direction. And to create this one, the one who talking about this is Professor Ken Ohata. And yeah, I agree with him that is to doing something like this. So how to create the tension? So we have two things to create the tension. The first is the cap. You use the taper cap to get into the submucosal layer, make the tension, and then cutting. And another thing is the gravity. You can use the gravity to make the tension and then cutting into the tension. So after knowing that how to do it and observing the case, during my case and do the whole case, and then training in the workshop and in the model, not in the real human. So I made a ESD training model. It's the cheaper one than the commercially one. I used the pig stomach, isolated pig stomach, and then one part of them. Because in Thailand, the pig stomach is easier, and then it's only $1, $1 for the one stomach. It's cheap and then easy to find. The concept is to know how to control the knife and how to control the scope. So after I made the model, I training my fellow. After the ESD procedure, the real case, my case finished, I use all of the equipment and the solution that left from the procedure to teach them, so it's not waste. And then let them learn how to controlling. At first, all of them, they believe that they can do it after saw my case, and they believe that, oh, it's not so easy, it's not so difficult, it's so easy. But first, when I let them learn to do, and then studying into the model, some of them cannot controlling the knife, and then they understanding that what is the difficulty. So this is
the major thing that I have learned is to move precisely. When I do the endoscopy, normally I move slow, but it's not enough. When I do the dissection, like the submucosal dissection, it needs to be more slow. Like if because it's just the 1 millimeter to move, and we need to move like the 3D dissection. It's not just a flat one to make the plane and complete the dissection.
So this is what they learn, and then after starting doing the dissection by themselves, they're understanding that how could we move, and they learn a lot about doing the ESD. So after the learning, so I asked them to review the whole case, the whole procedure case, uncut version. So you can find it on the internet, also in the Ohata Endo Salon, and also my channel, so that you can learn about we keep posting the long case, the uncut version, so you can understanding when the complication happen and something happen, and how could we correct the problem during the ESD. So please try to look at it. And as I mentioned that try the P-cutting EMR first. It's the good way to try to practice to control the knife and the scope. This is a case of the tubular adenoma, the flat one. And you can see when I first I would like to do the EMR, but after the injection and try to looping the snare, and when I close the snare, I believe that I cannot complete the dissection within one piece because it's like some part is not good. So I switched to the pre-cutting EMR. So you can use the cap or non-cap if you can control the knife. So cutting the circumferentially first, and then you can practice to control the knife and the scope to cutting in the place that you want to cut. And after the cutting, injection some more of the lifting to make it the wheeling is better, and then snelling with the complete dissection in one piece. It's like this. Yeah, and then close the lesion. Okay. So this is after the dissection. And then you can start your own case under supervision, of course. Yes, have someone to escort you first when you start doing the ESD by your case, but not start with this one. This is a difficult one. The hepatic fracture location, flat lesion, another big size, and then this is difficult. Don't start with this one. You can do it when you're familiar with the ESD procedure. So this is after dissection, and not for this one. Too big circumferential lesion, you will not succeed if you start with this one. But you can finish it when you're familiar with the procedure. It's like this. So, yeah, I recommend doing the rectum first. Small size, less than 2 centimeters, good start, and then to do the ESD. So this is all of the procedure that I teach our fellow in our endoscopy. And then please review the case in the Endoscopy 101. And then, yeah, now is like the conclusion. ESD is the good, safe procedure, better pathologic study, oncologic outcome is good. Not easy, but not difficult. You can do it. The learning is time consuming, dedication, that's what we need. If you can success, the patient outcome is your prize. Thank you.